Good evening, everyone. My name is Stacy Jean-Claude. I am the Outreach Program Manager at the MGH Kidney Transplant Program. And tonight we have great programs scheduled for you, talking about the recent OPTN, or the Organ Procurement and Transplantation Network's policy regarding wait time modification for previously disadvantaged patients, primarily African American or Black patients. We have Dr. Wynn Williams and Dr. Ivkovich with you tonight, and I'll let Dr. Williams introduce himself.
Great, thanks, Stacey, and thank you all for joining us this afternoon, evening, for this program, Bridging the Gap, Understanding and Implementing the new OPTN UNOS policy, addressing past disparities in estimating GFR equations for candidacy for kidney transplant. I'm joined this evening by my good, esteemed colleague, Anna Ivkovich, who is the lead transplant psychiatrist at the MGH Transplant Center. Dr. Ivkovich and I have worked many years together in the management of our patients who are candidates for kidney transplantation. And I'm happy that she's joining us this evening. And we're happy to receive any questions you might have regarding this policy as I take you through how it's being rolled out. So I am driving here, I think, and let's see if this. That's me. I'm the Associate Chief of the Renal Division here at MGH and a transplant nephrologist in the MGH Transplant Center. And I have no disclosures related to this presentation. So as we get started here, we're going to make sure that we give enough time for questions and answers, and please feel free to put them in the chat. I'm going to take you through basically a large sort of overview of racial disparities in kidney transplantation, and to give you some background for why these issues are important to national kidney allocation policy. We're going to talk about what it means to more equitably measure kidney transplant function, and then how equitable measurement leads to improving access to kidney transplantation through the waiting time modification that's now the subject of discussion for this presentation and the OPTN estimated GFR policies. So by way of racial disparities in kidney transplant, so this is a broad overview of chronic kidney disease in African Americans. So it's striking, and I think many of you know these data, that the overall incidence of end-stage renal disease in African Americans is about 3.5 to 5 times that of their white counterparts. African Americans constitute fully about 35 to 45%, over a third of the national dialysis population in the Medicare rolls in the United States. So that of more than 700,000 individuals with end-stage kidney disease in the US, approximately over a third are African American or are of African ancestry. And so this is a huge disparity, right, in terms of the CKD burden. The Black population by census in the US is about 13.6, call it 14% of the US population. But again, African Americans have a high rates of chronic kidney disease, disproportionate to their population distribution. And again, about a third or more are populate the dialysis rolls in this country. Now, one thing we've been studying, and I've done this at the national level in terms of policy implementation, are the barriers to transplantation. And many of you know that gaining the opportunity for a kidney transplant is a complex process, and it's a tiered process. I've talked about the rates of kidney failure in the minority Black community. You have first to get referred for a kidney transplant by your provider, your primary care doctor, internist, others who are providing care for you. And that referral is a formal declaration that this patient's going to be a candidate. And then you have to undergo a kidney transplant evaluation in a transplant center. And that evaluation is in and of itself time-consuming and fairly labor-intensive. We evaluate patients for their heart health, that in fact they're healthy enough to make it through the transplant operation, but they have no undisclosed or unknown chronic diseases that might interfere with immunosuppression and cause risk to post-transplant performance, like chronic infection, undiagnosed or occult malignancies. We want to make sure that we evaluate their vasculature, that they're able to receive a kidney transplant in a good position, in a healthy position. And then we want to make sure that they have the social supports in place necessary for good post-transplant care. And that entails a rather extensive psychosocial evaluation. So many different components to kidney transplant evaluation. Then a patient, if a patient's deemed suitable, is placed on the wait list to gain time for transplantation for a deceased donor transplant. And again, ethnic minorities tend to wait twice as long on the kidney transplant list to receive a first kidney transplant, again, than their white counterparts. So these are essentially tiered barriers, if you will, to achieving kidney transplantation. And this is brought to our attention really in a fairly dramatic set of publications in the early 2000s. This is one from our colleagues at the Harvard School of Public Health, John Ianian and Arnie Epstein, looking at ethnic disparities to the access for kidney transplant in 4 large geographic areas in the United States. And again, what this study did was to look at these tiered barriers, getting referred for evaluation for transplant, successfully winning now a place on the wait list, getting placed on the wait list, and then those patients who went on to receive a first kidney transplant. And what you see here is if in the green bar compared to white patients, comparing to the rates of African Americans achieving referral, there's about an 8% disparity, whites overarching blacks in this case, and then getting placed on the wait list, about a 15% disparity in the blue bars between these 2 groups, again, whites superseding blacks, and then a deep disparity, and an alarming deep disparity in those patients who received first kidney transplant, a 35% difference, whites, again, superseding blacks in terms of gaining access to first kidney transplantation. And this was an alarm bell, if you will, to national kidney allocation policy that many of us then coalesced around to try and change what needed to be changed in terms of mitigating these disparities. Now, if we turn our attention to measuring kidney function, again, many of you know sort of the basic rudiments of what it takes to measure kidney function. You can see that in this slide cartoon. Basically, we use blood testing and urine testing to give a gross estimate of whether a kidney is healthy. And the blood test is a part of a basic metabolic panel that most patients undergo. You've heard of a serum creatinine. That's a test that's generated in the basic metabolic panel. And that creatinine level, that concentration in the blood, is used to estimate the glomerular filtration rate, or GFR. And we'll talk about this in more detail. We we perform a urine test to look at the amount of protein in the urine, and that's a function or a reflection of kidney filtration function. You should not have heavy amounts or large amounts of protein in the urine. So proteinuria or albuminuria is also tested routinely. Now, if you see in the middle panel here, this is a GFR indicator. Normal is anywhere between 60 plus to 120, call 100 cc's per minute normal. And as the GFR falls to 60 or below, now you're in the area of chronic kidney disease. A GFR of 59 cc's per minute is CKD 3A, stage 3A. And as you move down through this panel towards 20, 25, 30%, 30 cc's per minute, call it now 25% of kidney reserve. That's an area where we begin to feel that the patient has moderately advanced chronic kidney disease and needs to be referred for kidney replacement therapies. And at Mass General and in general in the country, when your GFR falls around 25 to 30 cc's per minute, call it 25 to 30% of kidney reserve, we refer patients. Early referral to transplantation is strongly encouraged. Early referral for dialysis access placement or consideration of kidney dialysis renal dialysis replacement therapy is also indicated. Now, in terms of measurement of kidney function, this gets to be a bit more complicated. Again, as I said, 90% of US clinical laboratories report an estimated GFR when serum creatinine is measured. And the current, historically, the current estimating GFR equations, until very recently, the last couple of years, use a serum, these equations incorporate serum creatinine, including a so-called race coefficient, where patients categorized as Black or non-Black. And this race coefficient is generated by way of large cohort studies, the modification of diet and renal disease study here, the chronic kidney disease epidemiology and collaboration, CKD epi. These are large cohort studies that looked at measured GFR in patients, Black versus non-Black, and tried to then calibrate estimated GFR based on those measurements. Now, the measured GFR, this is technical, is done with an iothalamate marker that's a radioactive isotope that's excreted in urine, as opposed to the blood measurement you get upon blood draw. That blood measurement gives you an estimate of GFR. And so it was found that in general, measured GFR in Black individuals was higher than whites. And so there is a coefficient correction in the equations to account for those differences. And I'll show you that here. An MDRD equation reports a higher estimated GFR by a factor of 1.21. That 0.21 is 20% higher. That's an adjustment if the patient is identified as Black. The CKD epi equation, which included a larger number of Black patients in the study population, proposed a more modest race correction. That's by a factor of 1.159. The 1.59, that's 15.9%, call it 16% if the patient was identified as Black. And the equity concern here is that both equations report a higher estimated GFR value if the patient was identified as Black, suggesting better kidney function as a function of that equation. Now, how does that play out in real time? Here's an example of the CKD epi equation, 2009. It's a long equation, it's complicated. Here is the race coefficient times 1.159 is a modifier of the estimate. Candidate A is an individual who is Black, a 60-year-old male with a serum creatinine of 3.3, as you see here. Candidate B is a white individual, non-Black, 60-year-old male with an identical serum creatinine of 3.3. But you see their estimated GFR via the race coefficient in the equations are different, with an estimated GFR that's Black individual, 23 cc's per minute. For the white candidate, it is 19. And this is important because 20 cc's per minute is a milestone. It's a threshold which triggers eligibility for transplant evaluation or not. If you're above an estimated GFR 20 cc's per minute, then you're not someone who can move forward in transplant evaluation. So it makes a difference. So give you another example of the impact of the race multiplier in estimating GFR equations on CKD care delivery in African Americans. This is a study that was conducted at Mass General Brigham with the universe of patients that come to our attention here at MGB. And this is data from Malika Mindu, our good colleague at Brigham Women's Hospital. These investigators asked how many self-identified African American patients would be reclassified to a more severe chronic kidney disease stage if the race multiplier term was removed from the CKD epi equation. So they use CKD epi as the estimating equation as the standard applied in this study. And question 2 is, what are the potential consequences of reclassification on advanced CKD care, vascular access planning for dialysis, transplant evaluation? And so again, the background, as I've explained, that these equations have an inflation coefficient if you're an individual Black race. So by way of executive summary, what they found is that fully a third of African-American patients were reclassified to more severe CKD stage if you remove the race multiplier. And I'll show you that in the next couple of slides. The methodology was compared these racial groups, including African-Americans, hypothetically reassigned to an estimated GFR below 20 cc's per minute if the race multiplier was removed. And so here are the demographics of the study. These kinds of slides get to be a bit technical, but just draw your attention to the left two columns here, white and African-American. The number of patients here who are white are about 50,000, 49,150, about 2,200 African-American patients. And the only thing to show you here is that CKD stage 3A, 3B, 4, and 5, diabetes and hypertension, the rates of CKD at higher stages were higher amongst Black patients as compared to whites. The rates of diabetes and hypertension were higher in Black patients as compared to whites. The rate of congestive heart failure was higher in Black patients as compared to whites. So in general, the African-American population in this study was a bit sicker. Now here's the meat of the technical part of the talk, and just bear with me, follow along with me. On the left column is estimated GFR categories using the existing equations, including the race multiplier term, okay? And the stages are 3A through CKD5. 3A, to remind you again, this is the estimated GFR of in the range of 45 to 59, just below that 60 cc per mil cutoff. And here are the number of patients in that range, a full 1,167. These are African-American patients in this large MGB cohort. And across the top here is the same categories of stages of CKD, the same breakdown, but now looking at estimating GFR without the race multiplier term. And what this shows simply is this, that if you take these candidates in yellow who were rated as being CKD 3A with the race multiplier, if you take the race multiplier term out in red, here are the patients who are reclassified, fully about a half, 47% of that initial cohort. 550 patients are reclassified. For CKD 3B, a full 25% of patients, 1 in 4, were reclassified in red. And then for CKD 4, about 30 patients or 10% of this 300 patient cohort in CKD4 were reclassified. So in total, about 700 patients out of the whole orbit of African-American patients in this large MGB cohort, a full third of these patients were reclassified to higher levels of chronic kidney disease in this study. If you looked at that cutoff then greater than 20 or less than 20, where you get a trigger for transplant evaluation, fully 3% of the patients fit that category, about 64, call it 65 patients who were not being referred to transplant evaluation, who were not receiving this best practice evaluation for kidney replacement therapy. So this makes a difference. Important clinical decisions are being made on very small numerical differences in estimated GFR. Providers are using historically a race-based calculator to make clinical decisions. And this is an equity issue because in fact, the race correction factor was disadvantaging ethnic minorities. And so the idea here over the past 2 years at the National Kidney Foundation, American Society of Nephrology, that these estimators needed to be reconsidered or even eliminated. And that now is national policy across the nation, slowly but surely being implemented. Let me show you another example that I wanted to bring to your attention just in terms of how this plays out in disparities and allocation to the opportunity for kidney transplantation. And this is so-called preemptive waitlisting. That's waitlisting a patient who's qualified for transplantation, but who is not yet on dialysis. And why is that important? We looked at this with colleagues from the University of Pennsylvania, Peter Reese, Dr. Inyanya, looking at racial disparities and preemptive waitlisting and deceased donor kidney transplantation. and looked at what we found was this. This is the advantage of preemptive kidney transplant, that if you look at, in this analysis, Meyer Krishi did this analysis back in the early 2000s, the unadjusted graft survival of about 56,000 patients, deceased donor kidneys by dialysis time, your percent of event-free survival was better by far if you were transplanted before going on dialysis. That's a preemptive opportunity for transplantation. And no matter the dialysis vintage in their analysis, 0 to 6 months, 6 to 12 months, a year and beyond, your event-free survival was much less as compared to those patients who were preemptively transplanted. And again, that's transplantation without having to go on dialysis first. Now, this has been a problem in transplantation for 20 years. Kasicki, back 20 years ago, reported that Black patients were much less likely to receive a preemptive kidney transplant than white patients, and that this was a substantial disparity in our system. Yet, when kidney allocation system reengineering occurred in 2014, the transplant disparities in this system still continue to persist. And I'll show you that in the next couple of slides. In 2019, 11% of all adult deceased donor kidney transplants, about 2,000, were preemptive. White patients received 65% of those transplants. Black patients received only 17%, despite this being a year when the wait list was comprised of 38% white and about an equivalent number of Black patients, 31%. And what you see in the next slide is that these racial disparities over a 15-year period from 2005 to 2019 persisted, with whites here, the percent transplanted preemptively in blue, far and away exceeding those patients who are Black patients or other ethnic minority patients. And you can see that there's no narrowing in these curves. King and investigators analyzed national registry data and reported that if you look at compared to white patients, Black patients had an adjusted odds ratio, that is the proportion of those who go on to receive a preemptive deceased donor candidate as low as 4.41. That's a 60% decreased likelihood of receiving a preemptive deceased donor kidney transplant, and that this disparity was widening after the 2014 CAS reengineering of the kidney allocation system. Now, the other piece here to emphasize here is that preemptive waitlisting carries forward allocation priority. Even if these patients who are waitlisted with a GFR less of 20 cc's per minute started dialysis late, they still accrued, they still gained waiting time by having been listed early. So if you look at disparities of waiting time over the same period, in 2019, 48% of waitlisted white patients, but only 22% of waitlisted Black patients began to accrue or gain waiting time priority before dialysis. And you can see that here, that this is a preemptive waitlisting for kidney transplantation, wide disparities with white patients in blue as compared to other ethnic minority groups, and no narrowing of these curves over that 15-year period. So the point here is that diverse barriers to preemptive and deceased donor kidney transplant are a function of inequitable access, and that race coefficients in the equations that assign Black patients with a higher GFR at the same serum creatinine level as other patients is a substantial block to transplant center referral. Now let's turn our attention to the last section of part of the talk to look at changes to the OPTN UNOS estimating GFR utilization, the policies that are being rolled out currently to mitigate these disparities. So this is a policy that was established by OPTN in July of last year as a requirement to eliminate or establish race neutral estimated GFR calculations in listing criteria. So the OPTN prospectively going forward from July 2022 prohibited the use of estimating GFR equations that include a race-based variable. And so This requires transplant programs to assess their current wait lists and submit estimating GFR waiting time modifications for those candidates that were affected by race-inclusive estimated GFR calculations historically. And that was implemented in January of this year, 2023. The scope of this policy is to fix this specific inequity related to waiting list practices for Black or African American patients who were impacted inequitably by race-based estimating equations. What is not in the scope of this policy is addressing late referral to the wait list, addressing overall access to the wait list for all candidates, addressing overall program practices, or addressing larger healthcare inefficiencies in the US. This is really a focused program to fix this specific narrow inequity in the system. The policy requirements were implemented, as I said, January 5th, 2023. By January 3rd of next year, all kidney transplant programs are required to assess or to have assessed their waiting list for all registered adult and pediatric affected candidates, Black and African American, submit completed estimated GFR waiting time modifications if they obtain for these candidates, to notify all registered adult and kidney transplant recipients for transparency of the policy and to notify them of eligibility status, to submit attestation and their appropriate notification and modification requirements to to the OPTN. So first step is to send first candidate notification to all registered kidney transplants. We have now nationally to assess our program's waiting lists to identify registered candidates that have been affected by these race-based estimating GFR calculations, submit modification forms, support, in addition to supporting documentation, to send the second candidate notification to all registered candidates for the sake of transparency, then to submit an attestation documentation and continue to fulfill these requirements going forward. Candidate notification 1. So what we've done here locally, again, what's required to notify all our registered kidney candidates, to notify them of the requirements of the program. MGH is distributed to our wait listed patients in March 2023 via patient gateway mailing notification of this program. What else is to be included but not required, or other elements of the system, documentation required to get an estimated GFR waiting time modification, how patients can partner with their program to find their lab documents and so forth. There are other things that we can do to support patients in trying to explore whether in fact they've been affected by race-based equations in the past. In terms of determining candidacy, candidates registered as Black or African American or candidates for this adjustment, labs showing previous use of race-based estimated GFR calculations, and then to have the required documentation to attest to as evidence of this fact. Eligible candidates can include candidates registered from January 5th, 2023 until January 3rd, 2024, adult and pediatric candidates. Candidates can be multiracial, candidates listed for kidney, pancreas, for multi-organ transplantation, if they're also listed for an isolated kidney. The supporting documentation must demonstrate a race-inclusive calculation with an estimated GFR value greater than 20 cc's per minute, race-neutral calculation with an estimated GFR value of 20 cc's per minute or less. The criteria for eligibility was established to directly link the use of a race-inclusive estimated GFR calculator to the candidate's late access to the waiting list. So in terms of supporting documentation and tips for seeking support, we plan to work with referring nephrologists and candidates to look at whether in fact there are records that attest that lab values in the 20 to 23 cc's per mil range exist. If the candidate qualifies by dialysis, to seek documentation from a time earlier than their dialysis start of evidence of this kind of disparity. And if the candidate qualifies by GFR, estimated GFR, to seek documentation from an earlier time than their current wait time start date an estimated GFR on the OPTN computer system. These are ways in which to find out if there's evidence historically that the patient fits this category for mitigation. In terms of notification for the candidate notification, the second stage, what's required, again, to notify all registered kidney candidates after assessing individual transplant center waiting lists, to inform all candidates of their estimated GFR waiting time eligibility status, and their elements that could be included but not required, modified waiting time start date for eligible candidates, and so forth. At MGH, our focus, our intent is to distribute to waitlisted patients on a rolling basis as we plumb and explore patient chart review for eligibility. So what I've taken you through is a focus program to eliminate one of the diverse barriers to waitlisting for deceased donor kidney transplant. I've shown you evidence that this also is an impediment to preemptive transplant waitlisting. And these are system barriers that will require multiple remedies, I think, to improve equitable access. Again, we've been addressing health disparities in kidney transplantation for a good 3 decades, and still there is work to do. And you can see, for example, in this focused example, that the race coefficient in estimating GFR equations are in fact an impediment to proper and timely provider level of referral of patients who otherwise would be good candidates for kidney transplant evaluation. So to close here, the new OPTN waiting time modification policy aims to eliminate inequities in transplant candidacy based on the old race-based estimating GFR equations, which disadvantaged ethnic minority patients. This is an effort to improve opportunities for transplantation for all patients in the United States, and we all should rest assured that our system for transplantation is equitable and fair. The new policy enables a retrospective evaluation of listing criteria for minority patients based on their old estimated GFR categorization, and enables them to gain waiting time and priority based on the updated non-race-based estimated GFR measurements. And the goal of this new policy is to eliminate this age-old health disparity based on flawed measurement metrics. So I'm gonna stop there. Thank you for your attention, and we invite Q&A, and thank you very much for joining us. So Stacy, Stacy, I think the floor is open for questions and discussion.
So it looks like we have one question in the chat. Have you already or when do you expect to see the impact of these policy implementations / equity concerns, and how will these changes be monitored?
So I think I'm going to turn this over to my good colleague, Linda Walsh, who can give us some of the brass tacks of what's happening in our program here at Mass General.
I'm happy to. Thank you, Dr. Williams. Such a necessary modification that affects such an important part of our population. And we wanted to let you know that we've been an active participant in this new policy. And since, there's a lot of logistics that go behind the scenes, just creating the letter and making sure that it's, appropriate for all comers, and reading level, and all the things that go into, notifying patients. In the meantime, we are doing chart review, and there's about just under 200 patients on the Mass General wait list that are African American or Black, and out of 1,375 patients. So we've already done a pretty extensive chart review on 3/4 of those patients. We were able to find, I think the new technology today allows us to grab information from Care Everywhere and other affiliates of Mass General to see kind of how that trajectory of the GFR goes from 30 to 25 to 20, and we grabbed the the one that would qualify right at the 19 mark or 20 mark, and so we were able to go through and print those off, and making sure that we have all the documentation necessary for each patient. So we've we're methodically going through each and every patient. I think UNOS is being flooded right now. It's a national issue. I think everybody else is sending in their modification forms, but we do check in with them once a week, and they're going through our patients, probably a couple dozen per week. So we are working very closely to get these modifications done as quickly as we can. Each patient that would qualify for this program will get a phone call from their nurse coordinator, and also a letter explaining what your qualified wait time was and what it will be after the modification. So there will be that close contact with all of the patients that will be affected by this policy.
And I should have introduced Linda to the audience as our head transplant nurse manager. So she is really helping us lead this effort. Other questions?
So another question we did receive was, why were we not informed of this policy change until almost a year later? And I think we should make mention that there are two policies that were established or enacted, one July of 2022 and one January of this year. Dr. Williams or Linda, are either of you able to speak to that question?
Yeah, I mean, I think again, I'm gonna be deferring to Linda on all of these
Sure.
questions, but I think, to answer the question, these policies get ratified and enacted, but it's a process from UNOS, from the national committee level, then making their way into transplant centers. It's a process. It's a process that takes time. It takes time to implement all of the necessary steps for investigating how the center is going to be affected, to look at what kind of data, demographics, and statistics do we have on our patients that might be affected by these policies. So I think, writ large, it's kind of a process and evolution, and we achieve greater clarity and more granular implementation as time moves on. But Linda, what do you think?
No, I think you're correct. I think in July of 22, they're basically just getting rid of that, race-based inequality of the GFR. And then in January was basically, how do you modify it? Okay, so we're moving forward from July. There was no more, inequity when we listed patients. But then as of January of 23, that was when we really started implementing what in fact do we have to do to get this modification put into place in every transplant center is treated, in every patient is treated equally. And I think, as Dr. Williams said, the first thing you have to do is make sure that how patients identify. We want to make sure that we're capturing all the patients on the list that identify as African-American or Black. And that was the first thing that we did. We actually took UNOS and we took our EPIC database and made sure that anybody that was, kind of not staying, we made sure we reached out to each and every one of those patients to be sure that we had the correct identifying race in the system, so that everybody would qualify according to how they identify. So there's lots of steps to it. We do have a year to do it. It is going to take time, and I think we're one of the larger centers. I think every center is going to roll it out as obviously as quickly as they can. And we want to advantage our patients as quickly as we can as well. So we've jumped on board, and we're really happy to say that we meet weekly to make sure that any letters or anything that we need to talk about as a team are being constructed and being available, as well as we have an equity coordinator. Her name is Isabella, and she is been helping with a lot of the behind the scenes work for this project as well. So we're fortunate to have the infrastructure to roll this out pretty quickly.
Yes, and just to piggyback on what you said, Linda, Isabella, who's our health and wellness navigator / coordinator, she's part of our equity and kidney transplantation initiative that we launched last year, aimed at helping all disadvantaged patients from minority communities, as well as those who are disadvantaged rurally, or I should say geographically, or due to socioeconomic standing. And so we're fortunate to have a really strong team able to support these patients. And speaking of the team, I wanted to direct this next question to Dr. Ivkovic. So we've actually received a lot of comments, more so than questions, about the anxiety and the stress that this particular policy has induced in some of our waitlisted patients, not just here at MGH, but nationwide, really. Can you speak to that, Dr. Ivkovic?
Sure, happy to. I would say, and I almost came up with some slides to talk about stress management, but I know we've been working, and Linda's been working really hard to get a better sense concretely of, how is this going to impact, non-minority patients? Because I'm sure, that's the big question for many waitlisted patients right now. What is this translating into in terms of how much longer might I be waiting? The specifics, we don't have the answers. We're working through that. We're trying to get our more specific information to everyone as soon as possible. So that's the biggest thing, is like, whenever there's change, this applies for this change in UNOS policy that is so important, but it's still a change. And it happens with COVID pandemic, it happens with any change. It's really extra important to just take good self-care and really get as much information as you can. And that's part of our job too, is trying to provide you guys with as much clear, concrete information as possible. And we're kind of learning in this process with you guys as well. So I would just say, focus on stress management as best as you can, because this probably is stressing out some of you, probably most of you. And it could also be very welcome news, but sleep prioritization, stress management, and if you feel like, your emotions are really getting kind of out of control, I would just say that's a really good indicator to maybe seek some help. So, just reach out to us. You have a whole team of clinicians here who are trying to get you guys as good at care as possible.
Thank you, Dr. Ivkovic. I see another question in the chat. Do you see waitlist disparities for African-American or Black patients with end-stage renal disease that are highly sensitized?
So the answer to that question is yes. And this was part of the kidney allocation system reengineering in 2014 that increased priority for patients who are very highly sensitized. Those patients who are in the very high realms of sensitization, say 95 to 100% highly sensitized, many of those patients, the majority of those patients actually are ethnic minority patients. And so what changed in 2014 was the historical system. If you had a greater than 80% what's called panel reactive antibody, that's a measure of sensitization. If you were over 80%, you were characterized as highly sensitized, and you received 4 points in allocation points for that level of sensitization. That was eliminated, and now we have a sliding curve that really progresses exponentially through all tiers of sensitization beyond 80%. So you get exponentially more points as you approach 100% sensitization, and that's driving allocation of kidneys to the most highly sensitized patients in the system. And again, many of those are ethnic minority patients. I see another question from Angelique. Hello, Angelique. Have you already or when do you expect to see the impact of these policy implementations, equity concerns? How will these changes be monitored? I think that's an excellent question. If you look at some estimates of the disparity that race-based equations have rendered ethnic minority patients, their waiting time has been delayed by on the order of about, if I remember the figures, about 1.7 to 2 years. So whether in fact they will gain that measure of waiting time is a matter of data collection and outcomes. And so we have to see what these policy effects generate in terms of those data, whether in fact a ramp up in allocation and waiting time results in more rapid transplantation or not. And I think it's just going to be a matter of assembling the data. Any UNOS policy change of this order or magnitude needs to be monitored closely in terms of whether in fact we're closing the disparities gap. That's going to be a function of more clinical investigation and more outcomes research looking at the impact of these policies.
Thank you, Dr. Williams. Just to piggyback on that particular question about the impact and potentially how long it could take for someone to be transplanted with a deceased donor, could you talk a little bit more about living donation and how that is a very viable option, and in fact, the best option for transplantation?
Yeah, so there's a lot to be said there. And this is another area, unfortunately, we talk about disparities, but they happen at many different levels. So since, again, 2014, there has been some narrowing in the gap between deceased donor kidney recipients between all groups, all ethnicities. That gap has been narrowing. It's not completely closed. But if you look at live donor transplantation, related or unrelated, the gap is widening, especially for ethnic minority folk. The real advantage of a live kidney donor, whether it's living related or unrelated, is that those kidneys on average, tend to have about twice the length of survival as compared to deceased donor kidneys. And that's measured in what's called the half-life of the kidney. The half-life of live donor kidneys, unrelated or related, is about twice as long as deceased donor kidneys. Now, every individual is different, so you can't necessarily apply this hard and fast statistics to all kidney recipients, but on average, that's what we see with live donation. Still, there is a huge disparity in minority communities in terms of live donors coming forward, and that may be, again, one of the things that we're addressing with our equity and transplant initiative. That's really important, that we bring a higher level of health literacy and really kidney and transplant education to the community to let them understand the benefits of why it's good to be a donor, a live donor, how it helps patients who are in dire need of the kidney. Again, if you have that opportunity to have live donation before dialysis, that preemptive transplantation really bodes well for how well patients do after transplantation. And it's a huge quality of life and survival benefit. So a lot to be done on the live donor transplant in that space.
Thank you, Dr. Williams.
I just wanted to comment on live donation in this policy, just to kind of correlate the two. So the wait time doesn't really matter when you have a live donor. So whether you're an NKR or whether you have a live donor, the wait time for any patient of any minority doesn't matter. It obviously gets you a kidney quicker. So that can be scheduled as soon as both the donor and the recipient are worked up and approved by the committees. So there's no wait time involved. So this modification would not affect any live donations.
Thank you, Linda. I also wanted to plug in, excuse me, our How to Find a Living Donor webinar program, which is open to our waitlisted patients. It actually goes over some myths and misconceptions about living donation, provides some tips and tricks. A lot of times, some patients will come into it thinking, I have no options, no potential donors, and then come out of it realizing, oh, my network has widened. I potentially do have other options. So if you haven't participated in this webinar program, I do suggest joining. If you want more information, please feel free to send me a message or an email. I'll put my email address in the chat. But do we have any other questions from the audience? All right. I will give it a couple more seconds, but in the meantime, Dr. Ivkovich, Dr. Williams, or Linda, do either of you have any parting words that you'd like to impart?
Yeah, I would just say in terms of, managing stress, we're talking about managing stress around what we understand is a fairly scarce resource. We have over 100,000 patients on the wait list for transplantation. We do on the order of 17 to maybe 20,000 kidney transplants a year. There's a huge excess in terms of demand as compared to supply. So this generates a baseline level of anxiety and stress as to, will I be able to realize this opportunity before too long? And I think we all understand that. I think the other piece here, though, is really speaking to appealing to our better angels. We all want to have a transplant system that's completely transparent, fair, and equitable, that all patients, all candidates have an equal opportunity to enjoy the opportunity for this really valuable, life-changing resource. And in that regard, the more work we do to uphold equity, I think, and fairness, the better we all are in terms of you know, how we regard our system as a whole. And so I think that may sound like a bit of altruism, but I think we all want to make sure that we have a fair and equitable system in place.
Dr. Ivkovich?
I'll just echo what you just said. I mean, that was very well put. We actually are thinking of coming up with a separate webinar, not to put Dr. Williams on the spot here, but kind of discussing just living with chronic kidney disease and managing stress and having a separate space for that. So we do appreciate the challenges all around of living with chronic kidney disease.
Thank you, Dr. Ivkovich. And Linda, parting
Sure.
words?
I just wanted to say this is really a team approach. I think, Dr. Williams and Stacy have really been at the helm, and we've had a whole team of people that have been working very closely on this. And I think when everything had to go out, all the letters had to be mailed out, 1,375 letters. We had a crew of people, stuffing those envelopes in and excited about this process. And really, the coordinators are diligently working amongst everything else they have to do every day to roll this out in a timely fashion. And I think I encourage anybody that if they have questions or concerns or anything that they want to ask their coordinators to reach out, because they're all part of this and we're all working very closely together to make it happen.
Right. Thank you, Linda. And for me, I'll say the team is really here for you all. Definitely utilize the Patient Gateway, which is our portal. It allows you to send messages to your coordinator and your other care providers. Please utilize that, especially if you have any questions about your position on the wait list. We are trying to communicate more frequently with you all through different channels, whether it's Patient Gateway, through these webinars, social media. So if you don't follow us on social media, please do. We do send a nice amount of updates there, and then we can also keep you up to date with the upcoming webinars, including the Facing Chronic Kidney Disease program that Dr. Williams and Dr. Ivkovich will be hosting later in the year. With that, I say happy National Donate Life Month. Thank you for joining, and we appreciate you.
Thank you all for attending. Angelique, thank you again for that very nice compliment. And again, I want to reinforce that we remain available, completely available for you for any questions and discussion going forward. Thanks for joining us.
Right. Bye, everyone.